Well, it's my pleasure to introduce to you a distinguished scholar, a senior fellow from the Cato Institute, Michael Tanner. And Michael has been to a Freedom Seminar before, and he's always illuminating. He has talked on this topic before. He is also an expert on Social Security and other entitlement programs. He's been with the Cato Institute for the last 20 years. He's the author of over 13 books. His latest book is entitled Replacing Obamacare, the Cato Institute, the Cato Institute on Healthcare. It's a collection of 10 years worth of Cato Institute's research on healthcare issues. He's also the author of Leviathan on the Right. He's been published widely in various media outlets, including the Wall Street Journal, and he's appeared on television and many media outlets, and we're very pleased to have him here today. So please help me welcome Michael Tanner.
Well, thanks a lot. I appreciate that. And appreciate the opportunity to come back and talk to another Freedom Seminar. It's always one of my highlights of the year, and I always look forward to it and hope we'll get some great question and answer time before this is all done. I was also fascinated by the opportunity to listen to the discussion of inequality and trying to make societies more equal before I came up here. I'm actually reminded, I don't know if any of you ever came across it, Kurt Vonnegut's great book on the topic. I believe it's called Kilgore Trout, in which he envisioned a society in which everyone was made equal. So if you were attractive, you had to wear a mask. And if you were an athlete, you were hobbled and had to wear around weights and stuff. And if you were smart, they put earphones on you that blared music into your ears constantly so you couldn't think. I'm convinced, by the way, that in writing Obamacare, most of the people in Congress were wearing those earphones. Not that they were necessarily, but we had that. I do want to talk to you today about the new health care bill because I think it's going to have a significant impact on this country and on your futures, both in the long term but in the short term as well. So I want to kind of walk you through, if I can, exactly what's in the bill. It is a little bit confusing. There's a reason why it's confusing. The health care law itself, the original health care law, was 2,409 pages long. It was just under 500,000 words, 477,000 words. That, of course, was not the entirety of it because of the way they ended up having to do this. In addition to the original law, there was also a reconciliation package which changed the original law. That reconciliation package was 153 pages or 34,000 words, which means the entire thing runs to just over 2,500 pages, 500,000 words. And I want to tell you, it is all fascinating reading. If you have nothing to do some night, I advise you to really pore over the 300 pages on the Indian Health Service. It's really fascinating stuff. But of course, this being Washington, just writing 2,500 pages isn't going to get you anywhere. This, after all, is a law that does say close to 2,000 times, the Secretary shall determine, and then leaves that wide open for what the Secretary shall determine. So they have, since the law was passed, issued 20,000 pages of regulations. And they are issuing new regulations almost every week. In fact, things that I would say a week ago in giving this lecture, they're now different because new regulations are coming out. Usually, for some reason, these regulations come out late on a Friday afternoon after the reporters have all gone home. Then they have this big regulation dump, several hundred pages come out, and they hope that no one notices them over the weekend when everyone has better things to do. But they are out there. And as you can imagine, this has greatly simplified the American healthcare system. This is what it now looks like. Down the bottom corner there, the patient goes in, and if they make it all the way through the maze, they can get over to the right-hand side here, and they can see the actual doctor. Now, I will say, in fairness, this is, of course, a partisan document. This was prepared by the Republican staff of the Joint Economic Committee. So I think it probably makes things look a little more complex than they really are. And if you know anything at all about the Cato Institute, you know that we are relentlessly nonpartisan. So we weren't about to accept, a partisan display here like this. So we actually went back ourselves, and this is how we actually think the healthcare system looks now. As you can see, it's much simpler. In particular, I'd call your attention to some of these beige boxes here in the middle. Don't worry, we won't ask you to memorize all the names here. But those beige boxes represent some of the 99, at least, actually I'm going to rephrase that, the at least 99 new agencies, commissions, administrators, czars, and so forth that will now have been created by this law and will oversee various aspects of the healthcare system. I do say at least 99 because we don't really know how many there are. The GAO, the Governmental Accounting Office, actually looked into this last fall, and they came back with a report that said they were unable to determine how many new agencies and so forth were created by the healthcare law. Because so many of these agencies, commissions, administrators, and czars actually have the authority to create additional agencies, commissions, administrators, and czars. And they don't know how many they will in the end. So they don't know until it's all played out exactly how many of these new agencies will be created. But as of last fall, there were 99. So we know there's at least that many going forward. There probably will be a few dozen more at least as we move forward. So it does look a little bit confusing. And I can't blame anyone for not pouring all through it. But there are ways to simplify it. And I really think if you want to get by, all the stuff on the Indian Health Service, if you want to ignore the sections on how vending machines have to properly display the calorie count of Twinkies, all of those sorts of things that are in there, you really can boil this entire law down, I think, to 5 key concepts. And those are the 5 concepts I really would like to walk you through today, if I can. And I think if you get those, if you understand those, you'll have a pretty good idea of what's in the law. And the other stuff we'll just have to keep finding out what's in it now that it's passed, to quote Nancy Pelosi. So let's start with the one right at the top. This is the one that's the most controversial aspect of it, if you will. It is the one that went all the way to the Supreme Court. It's still, if you poll people, it is the single most unpopular aspect of the law. That is the individual mandate. Now, this is a requirement under the law, the individual mandate, that says that if you do not receive health insurance from some other source, particularly if you do not receive it from a government program, such as, say, Medicaid or Medicare if you're over 65, some military programs, although there's some ambiguity in the law on that, but things like TRICARE and so on in the military veterans health care. If you don't get health care insurance from there, or you don't get health insurance provided to you on your job from your employer, then you must buy health insurance for yourself. At that point, you must go out and purchase your own health insurance. Now, there's a couple of small exemptions in there. There's a religious exemption for the Amish, for example. There's a small income-based exemption, but for almost everybody in America will be required to purchase health insurance for themselves. If you fail to do so, you will be subject to a penalty or a fine, or as the Supreme Court has now defined it, a tax. That begins January 1st of next year. On January 1st, 2014, this individual mandate goes into effect. Now, in 2014, therefore, the fine, penalty, or tax will be 1% of your adjusted gross income. In 2015, that goes up to 2% of your adjusted gross income, and in 2016 and forever thereafter, it becomes 2.5% of your adjusted gross income. So you have either the choice of buying the health insurance or of paying the fine or the tax, in effect, for not buying the health insurance. John Roberts specifically said it's a tax on the privilege of not buying health insurance. I've said. Now, there's a lot, you can get into economic arguments about pooling and all sorts of stuff, which is why they did it this way and had the mandate. And there's all sorts of philosophical arguments about why it's an infringement on individual liberty to force people to buy health insurance. But most people, in the end, probably figure that it doesn't really apply to you. This is about people who don't have insurance having to buy insurance. And most people, and I would assume most of you, have health insurance. And therefore, if you have health insurance, and it says you had to buy health insurance, well, it doesn't really have anything to do with me. Not quite. Because think of it this way, if the government's going to say that you have to buy health insurance, then the government has to say, what is health insurance? I'm pretty sure that the policy that I bought down at Walgreens for $9.95 with the $10 million deductible probably isn't going to cut it. And, in fact, it would not. The law is actually pretty specific about what is and what is not health insurance. It can't have deductibles of over a certain level. It can't have co-payments that apply to certain procedures, particularly preventive care, or what they define as preventive care, which is pretty broad. It can't have annual or lifetime limits. You used to be able to get health insurance, for example, that paid $2 million in benefits over the course of a year, or up to $10 million over the course of your lifetime, something like that. It can't be insurance like that. That no longer is considered insurance. It also requires certain specific benefits have to be in every policy. For example, health insurance must now cover mental health benefits at parity, which means at the same level as physical ailments, you have to pay the same level in terms of mental health benefits. It must include drug and alcohol rehabilitation therapy, which is every college kid likes, but it must cover therapy for that. It must cover prescription drugs, which is one reason why the pharmaceutical industry spent $150 million advertising in favor of this legislation back when it was being debated whether or not to pass it. It must cover dental and vision care for children under the age of 18. It must cover educational services for children with autism. It must cover, and this is probably one of the most controversial aspects. This has gotten a lot of press. But it must cover contraception, sterilization, and abortifacients. Must be covered by every piece of by every health insurance plan. So what does that mean for you if you have health insurance today, and you're perfectly happy with the insurance plan you have, but it doesn't meet this definition? Maybe the plan you have doesn't cover contraception, or it doesn't. It has a deductible that's too high, or some other variation from what the government says is acceptable health insurance. Well, there's actually a little bit of good news for you here. You are grandfathered into your current plan, meaning that if you have health insurance today and it doesn't meet the government's definition, you don't have to change insurance. Unless. And with this legislation, there's almost always an unless. Unless you make any change to your current insurance. So if you change, obviously if you change carriers, if you're on a plan sold by Cigna and you change to Aetna, that's a change. But also if you change your deductibles in your plan, you change your co-payments in your plan, you change the benefit structure in the plan. It used to cover mental health benefits at 70%, you want to change that to 75 or 65%. Anything like that is a change. You're on your parents' policy right now, you go off, you get a job, you get insurance on the job, that's a change. Anything like that is, so as soon as you make any change at all to your plan, you must immediately bring your plan into compliance with the government's definition of insurance. So if you have insurance today, doesn't cover mental health benefits at parity, but you change the co-payments on that plan, then you must cover mental health benefits at parity. You must bring that in. So you're going to, this is not just about having insurance. You must have the insurance that the government has designed for you. And you must get that insurance even if that insurance is more expensive than the insurance you have today, or it has benefits that you have no interest in whatsoever, or even if it has benefits that you're morally opposed to, you must have the insurance that the government says that you must have. So with the individual mandate, it really does affect pretty much everybody. In fact, they looked at insurance plans that people have now. And there was a company called Health Packets out of California that did a survey of over 10,000 insurance plans and looked at these and said, well, how close do they come to the government definition of insurance? What they actually found out was that only 2% of all insurance plans in the United States met the government's definition of insurance. Most were pretty close. Most were, or actually I won't say most, but some were pretty close. For example, the new definition says you have to provide X number of days in the hospital after you have a baby. Maybe they only provided Y number of days in the hospital. So it's a small change, but it's still a change. What this chart actually shows, though, is in the different states how close the average plan is to meeting the government's definition. What you can see is in Massachusetts, they're between 90 and 100%. That's where under Romney Care, they've already had this in place pretty much. They're already meeting pretty much the government's definition of insurance. Most plans are in place there. But you can see in the red states, they're pretty far out. They're not even close. And in the sort of the orange states, including Michigan, they're between 70 and 79% in terms of actuarial value of the government's definition of insurance, which means there's going to be substantive changes. It means that the average plan in this state probably doesn't meet the definition of the government's plan, and you're almost certainly at some point going to have to change. In addition, while you are grandfathered in, your insurance plan is not. What I mean by that is that you can keep your current insurance if it doesn't meet that definition, as I said, as long as you don't make any changes. But that insurance plan cannot sell to anyone else. They can never sign anyone else up to that plan. Now think of what that means for an insurance company after a while. Where they're selling this plan, people are making changes, and every time they make a change, they have to drop out of that plan. So eventually the number of people in that plan gets smaller and smaller and smaller. Now, the smaller a plan gets, the fewer people it has signed up, the harder it is for insurance companies actuarially to make decisions on pricing that plan. So down the road, a couple of years, they're going to come to you and say, we just don't have enough people in that plan anymore. We can't sell you that insurance. And they're going to make you change. And at that point, you're going to have to come into compliance with the government's definition. So ultimately, in the end, everybody is going to have to change their plan in order to comply with the government, what the government wants in terms of insurance. So the individual mandate isn't about, in the end, people who don't have insurance. It's about everybody having to change their plans. Now, the second part of this is the employer mandate. This goes hand in hand with the individual mandate. You remember, the individual mandate affects you if you don't have a government plan or an employer plan. The employer plan says businesses that have, we think, 50 or more employees must provide health insurance to their workers. Now, I say we think 50 or more. This is one of the problems when you write 2,500-page bills the night before you pass them without anybody reading them. You actually have consecutive paragraphs in the legislation where it says, if you have 50 or more employees, you must provide health insurance, and then the next paragraph it says if you have 50 or fewer employees, the mandate doesn't apply to you, meaning if you have exactly 50, it's a little bit vague. However, the way other parts of the legislation read and the way this is traditionally done, which almost certainly is 50 or more, so let's just assume that if you have 50 workers, it applies to you. If you have 50 or more employees, you must provide health insurance to your workers. And once again, not just any insurance will do. If you're providing them with insurance and it doesn't meet the government's definition of insurance, the same rules apply as with the individual plan. They're grandfathered in, but any change made to that plan, and it must come into compliance and provide all the benefits that are required. This is why some employers who have religious problems, for example, Notre Dame University objects to the idea of providing abortifacients to their employees. And so they are now suing. There's a Christian toy company called Hobby Lobby, which is got I think the suit that's furthest along these lines. They don't want to provide the contraceptive and abortifacient coverage under this, but they would have to under this legislation. If you fail to do so, then you're subject to the fine, penalty, and so on. In addition to having to provide the insurance, employers must also pay for a certain amount of the employee's insurance. They must pay for at least 60% of the cost of that insurance plan for the employee. And they must also pay for enough of the premium so that the employee does not have to pay more than 9.5% of his family's adjusted gross income for that insurance. So if they have to pay at least 60%, but if paying that 40% out of pocket means that the employee ends up paying more than 9.5% of his family's adjusted gross income, then the employer would have to pay more than the 60% in order to make up for it. Now, a couple of problems with this. One is, note that family's adjusted gross income, which means that employers are actually going to have to ask their workers to turn over their income tax records in order to prove what the family's adjusted gross income is, so that they would know how much of the insurance premium they're going to have to pay. We think they're going to change that because we think that employees will tell employers exactly where to go as soon as they're told, oh, by the way, one of the things you have to do if you work here is give me all your tax records. We don't think that's going to work. So it looks like they're going to create what's called a safe harbor or an exemption to the rule once the employees tell you that you can get out from under that. The other thing, of course, you should realize is if employers are indifferent to how they provide compensation. They care about the cost of employing a worker. When you go out and get a job, the employer figures how much value you're going to provide to that company by your work and how much it's going to cost to pay you for that value. And they don't care how they pay you. They don't care how much of that is wages, how much of that is taxes, how much of that is health insurance, how much of that is contribution to your 401k, how much of that's a free parking space. Doesn't matter. It's just their cost of employing you. Well, if you tell them that they therefore are going to have to now provide you with health insurance, and that health insurance is going to be more expensive than the health insurance that they used to provide, and that they have to pay a certain percentage of your premium, might have been more than they paid before, well, okay, they'll pay that, but they're going to have to make up that cost somewhere else, right? Because they're not going to compensate you more than the value to your company. If the cost goes up higher than your value to the company, they're just not going to hire you. What they're probably going to do is simply pay you a little bit less. So they'll pay some more money for insurance, and you'll just make less money when you go get your job. That's the second problem with this. The third part of the law is insurance regulatory reform. There's a whole bunch of changes to the way insurance is done and the way insurance can be sold. Now, some of that I already mentioned. You can't have lifetime limits. You can't have annual caps on how much is paid out, all of these sorts of things. Some of these were, and still are, I think, popular in some aspects of it. There's now, for example, the requirement you can stay on your parents' insurance policy until you reach age 26. Now, in Washington, we call this the slacker mandate, but I know it's popular. There is a side effect to this. It turns out insurance companies don't do this for free. They actually charge more for those extra years of coverage. And what we're actually finding is that some businesses decided that, well, why would I bother, if I don't cover my employees' kids at all, I don't have to cover them till they're age 26. If I cover them, I have to cover them from 18 to 26. Maybe I just won't cover them at all and just save the money that way. So we're actually finding there's some side effects with that. that might not be quite as popular if this plays out, but right now that's pretty popular. There is a requirement that says that insurance companies must pay at least 80% of whatever they take in premiums, they must pay out in benefits. So if an insurance company brings in $1 million a year in premiums, they have to pay $800,000 worth of benefits that year. If they don't do so, for whatever reason, their administrative costs are too high and they don't pay out enough claims, they're actually required to rebate the difference. So if they only paid out, in that case, $700,000, let's say, in benefits, they would have to take $100,000 and mail everybody a check proportionately for what's left over, which is a very nice thing for people who get the checks. But squeezing down the administrative cost does, again, have some side effects. It means when you call your insurance company to find what's going on, you will be calling Mumbai from now on. You will be on hold for the next 12 and a half hours, listening to elevator music, all that sort of thing. But, there's trade-offs involved in all of this. There are two very serious regulatory reforms that are actually going to have a direct impact on you. So those are the ones I want to spend actually a little bit more time on. One of these is what's called guaranteed issue. And this deals with a very real problem in the health insurance industry. It has to do with the issue of pre-existing conditions. Now, you should realize what a pre-existing condition is that someone who is already sick. That's all a pre-existing condition means, is someone who's already sick. I'm talking about insurance for pre-existing conditions a little bit like driving your car into a tree and then picking up the phone and say, hey, Geico, now's a great time to buy that health insurance or buy that auto insurance. But when you're dealing with the pre-existing condition problem, it's real. You have people out there, they get sick, you lose your job, you lose your insurance, you go try to buy insurance on your own, the insurance company says, hey, you're already sick. This isn't a matter of risk. Insurance companies are about spreading the risk of something. If you're already sick, there's no risk involved. You're just telling me I'm going to have to pay a lot of money out to you. Insurance companies are naturally reluctant to do that. But how do you deal with those problems? I used to go out, I would debate this, the healthcare issue back when this was being up for whether or not they're going to pass this. And I would go out around the country to debate it. And inevitably, as I was debating it, there'd be this woman in the audience that they would introduce who had just been diagnosed with breast cancer, and as a result of that, she'd lost her job, and so therefore she'd lost her health insurance. And it happened to be right after the bank had foreclosed on her house, so she and her 3 special needs children were all out in the street, and she was trying to reach her husband in Iraq, but she couldn't because his leg had just been blown off by an IED, and anyway, they would then turn to me and say, so why don't you want this woman to have health insurance? Which was always a little tough to answer. But it's a very real problem. And the way they solved this in the law was to simply require that insurance companies sell you the insurance. They simply said, okay, person walks in your door, they've got stage 4 brain cancer. That they say, insure me. You say, okay, I have to buy, fine, got to sell you the insurance plan, even though you're got 6 months to live and you're going to be hugely expensive for me as an insurance company. I've got to sell you the insurance. Again, there's a couple of little problems. One is that if I'm an insurance company and I know that every time someone walks in with cancer, I've got to sell them insurance, and I know it's going to be hugely expensive for me to do so, when I'm making up my network of physicians for my insurance company, am I going to go out and get that world-famous specialist in cancer to sign up to my insurance plan? Do I really want all these people with cancer coming to me? Or maybe I'm going to have one oncologist, just to say I have one, and he's going to live somewhere out in the woods and only have office hours from 3 a.m. to dawn, twice a week or something like that. I'm going to make it as difficult for you to get treated for cancer as possible so that you won't come to me. You'll go to this other company over there that's actually got people that treat cancer, but you're not coming to me because I'm going to make it almost impossible for you. So you're going to see problems with the quality of care. The bigger problem, and the one that affects you guys directly, is that if I'm going to be told I have to sell the people insurance, you're also going to have to tell me what I can charge them. Because it doesn't do them any good if they walk in with that cancer and they say, okay, sell me the cancer. I say, yeah, got no choice, got to sell you the cancer. By the way, the premium's $1 million a month. Doesn't do you any good. So what they did with the second part of this is something called community rating. And what community rating is it says you have to charge the same premium to everybody regardless of whether they're healthy or sick. You can't base the premium you charge them on their health anymore. Now, they actually allow 3 variations. They allow a geographic variation. So you could charge more. They haven't laid out what these geographic areas are yet. We don't know exactly what they'll be. But you can assume they're going to let you charge more in Detroit, let's say, than up in the Mitten because the cost of health care is greater here. So you probably charge a little bit more premium up there or down here. The second part of it is you can charge slightly more based on age. Used to always be, traditionally insurance companies charged about 9 times more to their oldest customers as they did their youngest customer. That was sort of the traditional margin. Some charged a little bit more than that, a little bit less, but it was traditionally about 9 to 1 on average. Under this law, you can charge no more than 3 to 1 difference. So they shrank that by about 2/3. And the other variation is you can charge 50% more to smokers than non-smokers. That's it. Those are the only variations you can make. So if you have somebody who is perfect health, they're an athlete, they run marathons every weekend, they couldn't be in better shape, and you have someone who is a 400-pound couch potato sitting there with a six-pack and a bag of Doritos every day, watching something on TV, they pay exactly the same premium. Now, this, I will tell you, is very good news if you're old and sick. If you're old and sick, your premiums, and I used to say your premiums are going to come down, but the reality is what they're going to do is go up more slowly than they otherwise would. But if you're young and healthy, you're screwed. As the premiums on the older and sicker folks come down, the premiums on young and healthy people are going to have to go up to meet them. And it's not even going to be halfway. It's going to be much more than that. So basically what this means is that they're going to force you to subsidize old sick people. They're going to raise your insurance premiums by a lot in order to lower the premiums on older and sicker people. And I've actually, later on, I'm going to talk to you about just how much it's bad. Put it that way. So that's I think, the key, the most fundamental insurance reform that's going to have a direct impact on you. I want to mention a couple of these other things here. There's also part of the law creates what's called insurance exchanges. This, I think you might have seen a lot of debate about in the paper. I know it's been big here in Michigan, the debate about whether to have one. Your governor wants one. Your state legislature doesn't want to create one at the state level. These can be either federally run or state run. The primary difference between the two, they're actually, you have no discretion if you set up a state one. You have to set up the state one the way the federal government wants you to set it up. But the difference is that if the state sets it up, the state gets to pay for it as opposed to the federal government paying for it if the feds set it up. So you can see there's a big advantage to having the state set it up because you can do exactly what the federal government wants to and then pay for it. But at any rate, exchanges, how can I explain an exchange? I mean, this one's actually always tough for me because, first of all, I actually make a living making fun of Congress. But sometimes they really are brilliant up there. I mean, sometimes they guess they need those headphones because they really are just amazing. And I want you to try to wrap your head around this idea of what the exchange is, because this one is going to be tough. But just try. They have created a place where buyers and sellers can come together. And the buyers will have money, and the sellers will have a product. And they'll exchange money for the product. Now, can you imagine that? How have we survived all these years without Congress? Now, it's true, I oversimplify. I mean, after all, Congress has gotten involved in this, so you take that concept and add 4,000 pages of regulations to it. But it is really, it's designed, that's the overall design, and what it's supposed to be sort of, I guess, is like a giant e-surance, if you will. You're supposed to be able to go online, and there'll be these insurance plans online, and people think I'm actually making this up, but this is actually the actual language of the legislation. That insurance plans will be awarded like frequent flyer miles. There will be bronze, silver, gold, and platinum level insurance plans. And at all the insurance plans at each level will be essentially identical. Sort of like Model T Ford, any car you want, as long as color you want, as long as it's black. You'll have essentially all the bronze plans will look exactly like all the other bronze plans. And then above them will be silver plans that'll have a few more benefits, slightly lower deductibles under them, but they'll essentially all be the same. And then gold and platinum and so on up above. And you'll be able to go online and say, okay, I want to buy a silver plan. Pops up the 4 companies that are offering the exact same silver plan, and you can pick from among those 4 identical plans online. And that's essentially what the exchange is. It's designed to make it simpler for you to buy insurance, because after all, if you have no choice, think how simple that is. It is also the mechanism through which subsidies are used to help people buy insurance. If you buy your health insurance on the exchange, and the only people, big businesses basically can't. Small businesses can buy on the exchange for their employees, and you as an individual can buy on the exchange as an individual. Big businesses cannot. So if you buy as an individual and go to the exchange to buy insurance, you can get a subsidy to help pay for your insurance. Now, this subsidy is available for people who earn up to 400% of the poverty level. That's for a family of 4, that's about $88,000 a year is the poverty level. Now, it's actually a little bit higher than that because there's some exemptions when you're calculating your income to see whether you qualify. Things like mortgage payments don't count as part of your income and stuff. So it's probably going to go up to about $120,000 a year. You'll get some subsidy. You may only get $1 or $2 at the top levels, but at the bottom levels you get your insurance almost completely paid for. However, there was a slight problem drafting the bill, and it turns out that the subsidy only counts for an individual premium, not a family premium. So if you actually had that family of 4 and you went in to buy the insurance for all your family, you could get a subsidy, but the subsidy would only be based on the cost of providing insurance to you. You'd have to pay the entire rest of the cost for your family. So they actually estimated that the cost for that family of 4 would be about $20,000 a year for a premium. The individual premium is about $7,000. You can get the subsidy against the $7,000, but you'd have to pay the other $13,000 out of your pocket entirely. So the subsidy is not going to really help anywhere near as many people as they thought. On the other hand, the insurance is a lot more expensive than they thought, so the cost of the subsidy is going to be a lot more than they thought it was in the first place. How you actually calculate those subsidies, you have to be a mathematician. There's some calculators online, thank goodness, because there are 2 separate subsidies, both done as refundable tax credits, which means you pay up front and then the next year and a half later they'll mail you a check. And the subsidies say one is against the premium. The higher the premium, the higher the subsidy you get. The higher your income, the lower the subsidy you get. So you have to plug both of those in there, and then there's a calculation that will determine what your subsidy will be. And then there's another one against the deductible of the insurance plan. So the higher the deductible the plan has, the more subsidy you get. The lower the deductible, or the lower your income, or the higher your income, the lower the deductible you get, or subsidy you get. You have to put both of those subsidies together, and you get 2 different checks to pay for those subsidies eventually. Simple as can be. They have already put out, by the way, you can go online and there's an application. It is 33 pages long. You also must provide your tax records with it because you have to provide proof of what your income is and all these deductions and exemptions and all of that with it when you provide this. So you have to fill out the 33-page application, which does include registering to vote, by the way. There is a thing in there that allows you to register to vote while you're applying for the subsidy. But you provide all that information plus all your income tax data, I believe it's for 5 years, and then you might qualify for the subsidy. So I can see an industry out there for anybody looking for something as a startup out there and helping people actually apply for these subsidies. And then the last part of this is Medicaid expansion, which is another form of the subsidy. This is actually optional for the states. Originally, the legislation mandated that states increase their Medicaid coverage up to people earning 133% of the poverty level would be eligible for Medicaid. Generally, almost all states already covered women and children at that level. So what we were primarily talking about here was adult men with no children. Now, think about this for men, adult single men particularly with no children. Think about what population this is. About adult men, single, no kids, with income so low or no job at all over an extended period of time that they are less than 133% of the poverty level. You're talking about your homeless population, your mentally ill population, and your chronically ill populations. Very high cost populations to insure. They originally required states to do this. The Supreme Court stepped in and said you actually can't make a state expand their Medicaid program. This was actually a 7-2 ruling. People forget that actually you had 2 of the liberal justices joined in with this. It was a 7-2 ruling. So states now have the option of either expanding it or not. Since they can't make you do it, the federal government is essentially trying to bribe states into doing it. And what they said was the states said, look, for the first 4 years, first 3 years, we'll pay for all of it. We'll pay you 100% of the cost of this expansion for the first 3 years. And then after that, we'll pay 90% of the cost, which is a much better deal than traditionally in Medicare. You pay about 40% of the cost out of pocket. States have to pay about 40%, feds pay 60%. They said, if we pay 90%, think of how much better deal that is. Of course, there's this little budget problem in Washington, and there's some doubt about whether or not they're actually going to pay that 90%. In fact, the Obama administration already put on the table as part of the fiscal cliff deal, for about 5 minutes, they put on the table the idea of doing away with that 90%. They pulled it back, very quickly, but they did put it on the table. So whether or not you can trust them or not, this once again is somewhat of a contention, I guess, between your governor and your legislature. Your governor says, hey, federal money, that's free money, I want it. And your state legislature saying, nah, we don't trust the feds to keep their promise, and they don't want to go through with it. If you actually want to look at the status of these things, this is the health insurance exchanges. The green states are states in which the state has set up the exchanges. The blue states are states in which it looks like the federal government is going to have to run all or part of them in those states. It's about 32 states that the federal government is going to have to run exchanges in. They are coming back to Congress this year asking for another $2 million to help set up the exchanges in the 32 states. Seems unlikely that this Congress is going to give them an additional $2 billion in order to do that. But we will have to see. And Medicaid expansion, again, the blue states are states that the governor has said he wants the money. The red states have turned it down. The asterisk for Michigan is, of course, because your governor said yes, and your legislature didn't approve it. So it's kind of up in the air there exactly what it's going to be. That's actually the case in a number of states where it's sort of undecided. But the red states have all turned down the expansion as of now. So that's essentially the keys to the legislation. That's what the law says it's going to do. But what I'd like to take is a couple of minutes, if I can, and talk a little bit more about what it means, not just what it says it's going to do, but what it's actually going to do. And one which I know everybody can't wait to find out is how much this is going to cost you. Short answer, a lot. Now, you know, there was actually a moment, and maybe you remember back during when this was actually being passed, just before the final vote, there was a moment, and Nancy Pelosi and Harry Reid and the Democratic leadership, they came out on the steps of the Capitol, and they were virtually just locating their shoulder, patting themselves on the back, because they got the cost of this legislation down to $950 billion over 10 years. And they were very excited by that. Now, you know, I've probably been around Washington too long, because I remember when $950 billion was actually a lot of money. You know, now I know it's a rounding error in the latest bailout, but at one time it was real money. That said, they might have undershot that a little bit, because they left a few things out of coming up with this $950 billion. For example, there's $115 billion in implementation costs that go with this legislation that wasn't included. In Washington speak, this is authorized but not appropriated funds, which means we're going to spend it, but we don't have to count it. This $115 billion includes, for example, as part of the president's budget just released, he wants to hire 4,000 additional IRS agents in order to enforce the individual and employer mandates that are going to have to go out and assign the taxes to people who didn't get their insurance and to determine whether or not you've got the proper insurance and all that. Well, those 4,000 IRS agents have to be paid, they have to have office space, they have to have staff, all of those costs go with it. There's all these regulators that have to oversee the new insurance regulations. There's the people who are going to have to run these exchanges. That all adds up to about $115 billion over 10 years. And you know, that money isn't in that $950 billion. Maybe it should be. They also do a little double counting when they're figuring their $950 billion. For example, Medicare. If you might remember the last really dreadful campaign that we just suffered through, there was this big debate about $716 billion in Medicare cuts. If you recall, Mitt Romney said, my God, the Obama administration's cutting $716 billion from Medicare. Isn't that terrible? The Obama administration replied, said, no, we're not cutting Medicare. In fact, we're actually expanding the life of the Medicare Trust Fund by 8 years. I looked at Medicare, said, it's $42 trillion in debt. I wish somebody was cutting it. But the reality was they were both right to some degree, or both wrong, if you will. There are $716 billion in Medicare cuts that are part of this legislation. But they then take that $716 billion that they cut, and they put that in the Medicare Trust Fund. Thereby, the Obama administration is correct when it says it expanded the life of the Medicare Trust Fund by 8 years. And then they take the money out of the Medicare Trust Fund, and they spend it on subsidies for the bill. Only in Washington can you spend the same dollar for two different things and count it in both places. So you count it both for expanding Medicare, and you count it for being available for the subsidies at the same time, but it's exactly the same dollar. They also do this with some Social Security taxes in there and a few other things like that, so there's a little bit of double counting that goes on. There's also, with the little measure, which I'm sure you've heard over and over again in the news, it's something called the doc fix. This was an additional $350 billion in Medicare cuts. It was a 23% cut across the board in Medicare spending in 1 year, $350 billion, 1 year Medicare cut. And this actually didn't have anything to do specifically with this law. This was actually on the books since 2001. This was a Bush administration item, this 23% cut in Medicare. And they passed it back in 2001. And then every year, Congress looked at this and deciding they didn't want seniors beating them to death with their canes, decided that they were not going to go forward with this, and they postponed that 23% cut to the next year. And then the next year they postponed it again, and they postponed it again, and it's been postponed every year since 2001. Well, in 2010, as they were going to pass this legislation, in order to get that cost down to $950 billion, they just assumed that in 2010, for the very first time, that 23% cut would actually happen. And then not to assume that anyone was cynical, but even as they were making that assumption, they introduced legislation to postpone that 23% cut. And when asked about that, they said, oh, but that's a whole separate bill. You can't count the cost of that bill against the cost of our bill. It's a whole different thing. You know, I figured, just think how much better off your budget would be if you could say, hey, my car payment's a whole different bill. That doesn't count. You know. So I think maybe you probably have to, it got postponed in 2010, 2011, 2012. By the way, part of the fiscal cliff negotiations they just did, they postponed it again. So it's never happened. It's never going to happen. So I think we ought to take that $350 billion and probably put that back in. And then lastly, there was a little issue with the way CBO does the scoring. And I like CBO. I think Doug Eberstadt is a terrific guy. I think CBO is a very bipartisan, honest organization. I don't think they stack the books. I think they're entirely straightforward. That said, they have to play by the rules they're given. Sort of a little bit of garbage in, garbage out. I mean, they're given the rules that they have to play by. And one of those is that they issue a 10-year forecast. So when this legislation passed and they said it was $950 billion, they were talking between 2010 and 2020. It was for 10 years. Unfortunately, this legislation doesn't actually spend any money until 2014. So they were actually only counting 6 years of spending, but counting it as 10 years of budget. And anything that happened in 2021 and thereafter, you just drop out of that doesn't count. Again, you know, your budget would be so much better off if you could just drop a week every month, and you know, and you didn't have to count it. Well, we said let's put all that money back in, and let's actually do 10 years. Let's start in 2014 and go to 2024, so we're actually talking about 10 years of spending. If you do all of that, then the legislation actually costs not $950 billion, but $2.48 trillion. And I would just mention, look at that trajectory. I can just tell you, after 2024, it's not getting any cheaper. Well, how are we going to pay for that $2.48 trillion? Well, we're going to pay for it with $1 trillion in new taxes over the next 10 years and $1.5 trillion in additional debt, which means money you get to pay. Just want to look briefly at the taxes. I'm not going to run through all these taxes here. I think a couple of them are particularly interesting. Some of them are pretty obscure. There's now a $63 per covered life tax in businesses. In addition to paying for your insurance, they all have to pay $63 per employee plus $63 per dependent for insurance they provide. Just something else is going to come out of your pay in the long run. The black liquor tax, by the way, just make you all feel better, it has nothing to do with alcohol. It's actually it's a pulp paper product that only applies in Wisconsin. So special tax there. There is the indoor tanning tax, number 6. This one I was shocked that it passed. It's a 5% tax on tanning beds. This passed despite the fact, and this is true, despite the fact that Snooki personally went to Washington and testified against this tax. That's true. That's how she became Twitter friends with John McCain during this testimony. But somehow she couldn't save it. So that went through as well. Anyway, a number of other these taxes now, a special tax on investment income, rent, capital gains, interest and dividends are now going to have to be subject to the Medicare payroll tax. Medicare payroll tax has been increased. You could just see a number of other taxes that are going to apply as we move forward on this. What about insurance premiums? Well, just before the law passed, the CBO looked at the insurance premiums and they said, if this law does not pass, insurance premiums will double in the next 6 to 10 years. Now that the law is passed, Congressional Budget Office went back and looked at it again and determined that having passed this law, health insurance premiums will double in the next 6 to 10 years. So essentially, this did nothing to reduce the growing cost of health insurance. It's going to double whatever is being paid now. And when you guys are paying for your own health insurance out there, you're going to be paying premiums that are essentially double what they are today. Now that's the starting point. That's the baseline. So the rest of this what I'm going to talk about, start with the fact that you're dealing with a doubling as a baseline, and then these other changes are plus or minus from that baseline. If you work for a big business and the big business provides insurance, that's probably actually grow a little bit slower than that baseline. There might actually be some savings for big businesses as part of this legislation. So for Ford, let's say, their insurance premiums will probably grow a little bit slower than the baseline would. Small businesses, pretty much right on that baseline. Small businesses are going to have their insurance premiums double over the next 6 to 10 years. Individual policies, if you buy insurance on your own, about a 10 to 13% increase over and above that doubling. And then if you're young and healthy, back to that again, you folks. A lot of estimates on this. They're all over the lot. The most favorable, the most optimistic estimate comes from the RAND Corporation, and that suggests that you would have about a 17% increase over and above the doubling baseline for you. Millman Associates, an actuarial firm, says about 30% increase. The American Society of Actuaries says about a 50% increase. The Council for Affordable Health Insurance puts it at 95%, and then it didn't make this chart, but the American Action Forum, Douglas Holtz-Eakin, former director of CBO, he went out and actually surveyed 1,000 insurance companies and asked what they would charge for someone who was young and healthy, and they said about 145% increase. That's after the doubling. It's on top of the doubling, actually. So it's about a 350% increase from the insurance premium now. So essentially, whatever you're paying now, figure 3.5 times that is what you'll be paying. Does it ration care, the health care law? And here I have to say, sometimes folks on the right got a little overzealous. There is no direct rationing in this law. With all due respect to the former governor of Alaska, there is no death panel in this legislation, in the sense that there's nothing there that says that they're going to send your medical records to Washington and somebody in Washington is going to decide whether or not you get heart surgery. And there's nothing like that in the legislation. That said, there are structures that it puts in place where it basically promises things that it doesn't have any money to deliver, so there's some question about what might happen there, particularly something called the Independent Payment Advisory Board, which affects people on Medicare. This is, again, it's not a death panel. What it does is it limits the growth in Medicare, theoretically. It says Medicare cannot grow faster than 1% faster than the economy as a whole, GDP plus 1. Why they want Medicare to grow faster than the economy is still a mystery to me, but at least they limit it to GDP plus 1. This is the so-called 15-member unelected board of politicians that Mitt Romney and Paul Ryan talked about a lot. What happens is if Medicare grows faster than the 1% above the economy, so let's say the economy grows at 3%, Medicare grows at 6%, this 15-member board, which is unelected, appointed by the president, confirmed by the Congress, must come up with a list of recommendations for how to reduce that spending by 2% back down to no more than 4 in the example that I just gave. Congress then can vote no on those recommendations. They cannot amend the recommendations, and they cannot vote on part of the recommendations. So if they came out with 12 recommendations, they can't say, we like 1, 4, 6, and 8. We want to amend number 3, and we're going to throw out the rest. They can't do that. They have to take the entire package as a package and say no. If they do say no, the package is vetoed. If they don't say no, the package goes into effect. If they don't vote, the package goes into effect. If one chamber votes and the other chamber doesn't, think the Senate, it goes into effect. If one chamber votes yes and the other chamber votes no, it goes into effect. Only if both chambers vote no does it not go into effect. Now, this is not a crazy idea. When you actually think about it, remember, Medicare is at least $42 trillion in debt. We're going to have to make cuts in Medicare. And Congress hasn't been particularly good about it. The idea was that they'd go back like when they did the debate closings, and they'd take the responsibility off of Congress. Congress could say, well, I really didn't like cut number 12, but I didn't have any choice, and it would sort of get them off the hook. And we might go forward. The problem was that having said they're going to make these cuts, they then said, oh, there's a few things you can't cut. You can't cut any of the benefits under Medicare. You can't do anything to make seniors pay more. So you can't raise their premiums, their co-payments, their deductibles. You can't make them have any greater cost sharing. You can't make seniors pay any more on this. You can't change the eligibility for Medicare, so you can't raise the retirement age or the eligibility age for Medicare. So what's left? Oh yeah, you can cut payments to doctors. And that's essentially the only thing they can recommend under IPAB, is they can cut back how much they're paying doctors. Well, this is what would happen to Medicare payments if that happened. This is from the Center for Medicare and Medicaid Studies, the government's own chief actuary on Medicare. Right now already, Medicare only pays about 80 cents on the dollar that's actually cost to treat a Medicare patient. That would decline to under 50 cents on the dollar if this goes forward. Now, if that happens, you can imagine what that's going to mean. It simply means that doctors are going to stop taking people on Medicare. And in fact, hospitals are going to close. The government's own chief actuary estimates that 15% of all hospitals will close as a result of this. Particularly inner city and rural hospitals will be the ones most affected, most likely to close. Well, look, at least we got universal coverage. I mean, that's why we did all this, right? There are 50 million, 60 million Americans without health insurance out there. At least we're going to cover them all. They're all going to get health insurance. I mean, okay, it costs a lot, and we've disrupted the insurance market, and you guys are getting it in the neck. But we're covering everybody. No. In fact, according to the Congressional Budget Office, by the 10 years of implementation, by 2023, there'll still be 33 million people without health insurance. We will cover 27 million, and we'll leave 33 million uninsured. And in fact, it's actually worse than that, because of those 27 million we're covering, only about 15 million of them are actually getting insurance. The other 12 million we're just sticking in Medicaid with all the problems that creates. The other 15 million will get subsidized insurance, but, wow, not much bang for your buck there, is there? And in fact, at the end of the day, there will actually be fewer people with unsubsidized private health insurance than there is today. We will actually have fewer people who who just get health insurance on their own without a subsidy from the government in private insurance markets than get it today at the end of the day. So actually reduce the number of people with private insurance. I'm just going to leave this up here for anybody who's interested. This is just the timeline of when various things are going to happen. The vast majority of them go into effect next year, January 1st of next year. That's when the mandates go into effect, and most of the other things that are, they're supposed to have the exchanges up and running, we'll see. Medicaid expansion, all those sorts of things are all supposed to take place next year. Most of the taxes have already gone into effect. Surprise, surprise. I think I'll close then with that and be happy to take any questions that you might have, assuming I haven't depressed everybody too much. Anyway, thank you all very much. Yeah. Yeah. In terms of state flexibility, states were always somewhat limited in what they could really do for reform, primarily because the big problem in our healthcare system has to do with federal tax treatment of health insurance. The fact that it's essentially employer-provided health insurance is a tax-subsidized product. Individually, purchased health insurance is a tax-penalized product. And that's created a lot of problems. The states were limited somewhat in what they could do around that. They were trying to experiment with Medicaid in particular. We don't know how much freedom they're going to be given. Initially, the Obama administration's position was no flexibility at all. You did the Medicaid expansion. You did it under the old traditional Medicaid program. We're not giving any waivers to anybody. They found that the governors really all said no to that. And now they're becoming a little more, there's a little bit of more negotiation going on, and we're seeing a little bit more flexibility in terms of that. In terms of some of the other changes, you can make changes to this beginning in 2018. You can sort of quasi-opt out of the federal requirements, provided you have a plan that meets or beats certain federal guidelines. Basically, you can go to a single-payer plan like Vermont is in your state. You can't do a more market-oriented plan. The way the benchmarks are designed is number of people with insurance that meets the federal definition, things like that. So it's almost impossible for a market-oriented reform, even if it was better or especially better on cost, to meet these requirements. In terms of Massachusetts, the Massachusetts plan really is almost identical to the federal plan. I mean, there's very little variation on it. The key concepts are all the same. Those 5 key concepts are all the same. Massachusetts has reduced but not eliminated its uninsured population. It always had one of the lower uninsured populations. It was around 10%, as most states was up in the 15 to 20% range. Massachusetts is always around 10. They've reduced that. They claim to 3%. The Census Bureau shows 5%, so you can argue that. So they've had a reduction in the number of uninsured at enormous cost. It has been hugely expensive in their state. They've already had a couple of tax increases to help pay for it. They are still underfunded by a significant amount. They have tried to respond to that by basically preventing insurance companies from raising their premiums. They put premium caps in place. The result of that is that all 4 major insurers in Massachusetts lost money last year, and they are beginning to squeeze provider payments to try to get back on that. Providers who are having their payments cut are beginning to stop seeing new patients. The average waiting time to see a doctor in Massachusetts has increased from 33 to 55 days since the legislation went into effect. So we have Canadian-style queuing going on in Massachusetts. And do I think it's particularly? Yeah, I think basically Massachusetts was designed the same way and also with the same goals in mind. It was an expand coverage goal, not a reduce cost goal. And I think we'll see the same thing in the federal plans. The cost we're already seeing on a year-over-year basis is exploding. You know, we got some expanded coverage for it. Not a lot of bang for your buck, but if your goal was to get at least one more person with insurance, we did that. And you know, hang the expense. And I think that's the problem we're going to see in Massachusetts with the same inevitable outcome, except they don't have the power to impose curbs on insurance premiums yet. So they'll just have to keep printing money for you guys to pay. Yeah.
How are like insurance companies supposed to survive? Like I know like as a young person, the last thing I ever want to do now, like after going through all this, is get involved with like health insurance. Like how are those companies going to be able to stay afloat with all these regulations?
The insurance, yeah, they're a little scared to death right now. First of all, the small and medium-sized insurance companies are gone. What you're going to be left with is probably the big 5. BUCA, it's called, Blue Cross, United, Cigna, Anthem, and Aetna, I believe. They're the big 5. They'll survive, but they'll be more like a public utility rather than an insurance company. They'll be privately owned. They'll be private stockholders, but their rates will be regulated. What they sell will be regulated. Everything, you know, they'll sort of guarantee this little tiny profit that'll truck along, and so it'll be like that. I think that's the most likely thing that's going to happen. They originally cut a they thought they were cutting a deal. They thought that they said, okay, you can regulate us, but force people to buy our product. We like that, 60 million more customers that have to buy our product. And not only do they have to buy our product, but no matter what we charge, you're going to help them pay for it. You're going to subsidize it, so we're good as gold. The problem was that it's already turning out that this pay or play, look, for you guys who are young and healthy, if we're going to charge you 350% more for insurance, or we're going to tell you you have to pay 1% of your income as a fine, or even 2.5% of your income as a fine, you ain't buying insurance. You're going to say, a few $100s a year to fine, I'll pay that. Especially if it means if you do get hit by a truck, you can buy insurance then. And they have to sell it to you. And the insurance companies have looked at this and said, oh my God, nobody who's not sick is going to buy insurance, and we're going to have this old pool of, and they're already going back to Congress saying, maybe we should postpone the insurance regulations until we get this figured out. And Congress is laughing. And so, yeah, the insurance companies are screwed, and they deserve it. Yeah.
You talk about these regulation dumps, and you made it seem like there's very little oversight as to what they write. I was wondering, what as like citizens, if we don't agree with some of the regulations they put into effect, what we can do to maybe change them or get them?
Yeah, well, I mean, a lot of them do have comment periods. In fact, but you have to find out that they've been issued. Then you have to find out when the comment period is. Then you have to find out who to send the comments into. And since there's dozens of agencies that are releasing this data, some comes from HHS, some comes from the Department of Labor, some comes from the IRS, Homeland Security is issuing, regulation. It's everywhere. And so you have to, and there's no one-stop shopping place where you can go and say, here's all the regulations. They just come out from these different things, but they're posted somewhere in the Federal Register, and you have to find them. If you do that, then you can write a response. You can basically, during the comment period, you can write into the agency and say, this is my opinion, which most agencies then promptly ignore. But you can do that. The other thing is to try to get Congress to overturn these, but of course, we have a gridlocked Congress, and very little of these things are going to change. So short run, there's not I hate to be negative on this. Short run, there's not a lot you can do. Long run, you can raise a ruckus. And they are, some things where the ruckus has been raised enough. For example, one of the taxes up there that I mentioned didn't go through was something called, it's a tax on medical device manufacturers. And this is, talk about your tough taxes. This is a 2.3% gross income tax. It's not a profits tax, not a net income tax. It's a gross income tax. So every dollar you bring in, you immediately have to pay 2.3% of that. And people think of medical devices, as MRIs and X-ray machines, stuff like that. Crutches are a medical device. Braces on a kid's teeth are a medical device. No one told Sandra Fluke, but a condom is a medical device. It's, so that's created a bit of a headache. And we have legislation. In fact, they had a non-binding vote already to repeal it. They just haven't done it because they can't figure out the $50 billion that they need to finance the bill, and they can't figure out what they're going to do if they repeal it. But legislation was introduced to repeal it. The lead sponsor of the legislation to repeal it, Al Franken. Why? Minnesota's the #1 state in the union for medical device manufacturers. Amy Klobuchar is a co-sponsor. In California, Barbara Boxer wants to repeal it. So you can raise enough of a ruckus, changes will come slowly. But ultimately, I think it's not fast enough to deal with the mess that's coming.
How will this affect our economy in the long run?
Well, the fastest growing area of the economy right now is really healthcare. #1 place for new jobs. People think it's terrible. We spend a lot of money on healthcare in this country. You can argue whether it's good or bad, but the money in the healthcare sector is just part of the economy. If we radically cut that back, I'm not sure whether that's good or not. Certainly, $1 trillion in new taxes, particularly taxes on investment, doesn't strike me as being exactly what you want to do right now. I think that $1.5 trillion in new debt is bad. We have, a huge debt in this country. You think the debt is, you have no idea how bad the debt is. Or maybe you do. Maybe even, if you know more than folks in Washington, you do. We talk about the $16.7 trillion national debt. Drop in the bucket. If you actually include the unfunded liabilities of Social Security and Medicare, our national debt is about $140 trillion. About 800% of GDP. Okay? We know our debt is bigger, when you include the unfunded liabilities of both sides, our national debt is bigger than every country in Europe except Greece. We are in worse shape than the Italians, the Spanish, the French, the Portuguese. we are in worse financial shape than they are. So let's add another, that's just over 10 years. Actually, the total added debt is $8 trillion, roughly. And that's discounted present value terms. That means if you had $8 trillion today, you could put it in the bank at 3% interest rate, you'd be fine. Well, so if the federal government come up with $8 trillion, we don't have anything to worry about. That's just the added from the cost of this legislation alone. Not good for the economy. Small business says the number one reason why they're not hiring, and survey after survey, is fear of this. Look, if you have, think about this. If you have to if you have 50 employees, you have to now, in addition to paying them, have to provide health insurance, which costs, for that employee about $7,000. If they're not $7,000 more, more productive, that's a big problem. So if you had 49 employees today, how quick are you going to be to run out and hire the number 50? Yeah. Yeah, they're trying to get under what they're trying to do is get under the full-time employee mark. The full-time employee is considered 28 hours a week, average employment. 27 hours is a part-time employee. For purposes of calculating whether you have 50 employees, 2 part-time employees count as 1 full-time employee. So if you had 40 part-time and 40 full-time and 20 part-time, you'd have 50 employees. But maybe if you moved a couple of those part-time employees back down under, to cut their hours back enough, then you can get out from under that.
Now, we talked about earlier, like if you're Amish, you don't have to pay for the insurance. But how does the government determine if you're Amish or not? Then they're kind of getting religious rights too.
Yeah, that's been a case for a long time. Amish don't pay Social Security taxes, for example. It's not specifically Amish. I think Ammonites and a couple of other groups could do it. Basically, what you have to do is prove that it's a long-standing tenet of your faith not to participate in these structures. That's been since the Social Security system was created, that they simply operate outside of these traditional social insurance structures. So the same exemption was created for them. That was in there. By the way, there was just so you know, there was an internet thing going around that says that Muslims did not have to participate. That's not true. That they're in, because it's not a long-standing tradition part of Islam not to participate in social insurance.
Going on there, if you're like a devout Catholic, can you say that you don't believe in contraceptives and then opt out that way?
That's before the courts. And what they are saying is that the administration position is that they are not making you use contraceptives or even making you pay for contraceptives. They're simply making you pay for insurance that covers contraception. They're making them pay for insurance, and it's the paying for insurance that's against their mandate. Catholics don't have a problem with paying for insurance. It's a specific benefit within the insurance, and they're saying that you couldn't mandate that the Catholics provide the contraception. You can't say the Catholic hospital must provide contraception unless it receives federal funds. But saying they have to buy it for their employees, they have to provide insurance, and they've created this weird mechanism whereby it's actually a separate insurance plan with the money moving around. And the insurance companies aren't supposed to charge you any more for the extra contraception coverage, so there's no extra dollars involved. It's a very convoluted way they've devised this. And basically, they have exempted churches as well. I should say a Catholic church does not have to pay for the insurance, but a Catholic school or a Catholic charity does. And so that's why they're coming back, and this is all before the courts. Anything else?
Is Congress exempt from the new health care laws?
Yes and no. They're essentially the mandates apply to them, but they all have employer-provided health insurance, so it doesn't really matter.
So the people that are making the laws don't have to follow them?
Well, that's nothing unusual about that. The plan that's essentially the exchange plan is based, in essence, on the silver plan, or one of the Blue Cross Blue Shield plan of the Federal Employee Health Benefit Program, which is everybody in Congress has anyway. So they're not mandated to be part of it, but they are part of it.
So you talked about how hospitals would no longer be profitable and you would see them going out of business.
Right.
So then that means that more business would have to go to hospitals to stay in business, and then they would be losing more money. So
Yeah.
then the government's going to have to provide hospitals.
Yeah. Yeah. Look, there is no way this legislation works. I mean, I have some sympathy. I talk to my friends who are single-payer advocates. And I say, look, I don't agree with you. I think a single-payer has got a lot of problems, but I know how a single-payer system works. I mean, actually, I see it goes in here, comes out here. I know how it's supposed to work in between. I just disagree with it, but I understand it. Market-based system, which is what I favor, I know how it's supposed to work. I mean, it comes in here, goes out here, I know what's in the middle. I look at this thing, and I haven't a clue how this actually works. I mean, you have essentially a pay-or-play system in which it is always cheaper to pay than to play. Anyone who's young and healthy and smart is going to drop out. Businesses are going to discover that it's better to pay the penalty than to provide health insurance to their workers. They're going to drop out. You're going to send everybody to the exchanges where they're going to be subsidized, except that the subsidies aren't enough to pay for the insurance. This thing's going to blow up. The cost is already going through the roof. Federal government's going to run 32 exchanges on state level, knowing state insurance law and all that sort of stuff. By October, they're supposed to have it in place. They've had several hearings. Jay Rockefeller, the other day, came out and said that he didn't think this could work and thought it was one of the stupidest pieces of legislation he'd ever seen. This is the guy one of the guys who helped pass it and still supports it, but he thinks he doesn't understand how it's going to work. So, people ask me, what do you think is going to happen to the healthcare system? And my answer is that I don't know. I think that the next 10 years of the healthcare system is going to be absolute chaos. I think that you're going to have companies going out of business. You're going to have companies trying to pop up and find market niches in here. You're going to have the insurance premiums skyrocketing, people dropping out of the markets. I can tell you a couple of things I think are going to happen. I think that independent physicians are gone. I think you're going to have two types of physicians. You're going to have those who are hospital employees, in effect, and you're going to have those that go into what's called concierge medicine, where they don't accept insurance or Medicare payments or anything, and they just work privately. I think that you're going to have big companies buy little companies, big hospitals will buy little hospitals, big insurance companies will buy little insurance companies, and the little insurance companies will go out of business. Little hospitals will be bought up. I think beyond that, I don't know. I can tell you that 10 years from now, I don't think the healthcare system will look anything like this legislation. But I don't know what it will look like. And I think, frankly, we're going to go through hell to get there. Thank you all very much.